It's an honor to welcome you to the here, but also online, at the most beautiful, in my opinion, and vibrant city of Europe, Amsterdam. And I'm really looking forward to all the intellectual discussions we're going to have and learning more about innovative implementation strategies to fight malnutrition. And I think with 20 countries participating in this conference, either here or online, this should be a success. So a little bit of background. So the city of Amsterdam, like other bigger cities, but also smaller towns, is basically struggling with an increasing amount of people of older age. And it has been estimated that 16% of the Amsterdam population will be over 65 years of age by the year 2030. And keeping in mind that studies from the Netherlands showed that 3% of people 65 to 69 years of age and even 15 to 20% of people over 75 years of age are malnourished. Amsterdam has to get ready. I did some calculations for about 21,000 malnourished patients just living independently at home by the year 2039. And this does not include people that are in a home care or nursing home facility. So the actual number is even way higher. So is Amsterdam ready for this? Who will diagnose those people suffering from malnutrition? Who will treat them? How we will treat them? And how will we do or organize the follow-up? I'm sure we're not ready for this, at least not in Amsterdam. And I hope that new concepts and insights from you, participants, healthcare providers, patients, policymakers, will shape this new nutritional landscape to make us ready for this and help us either prevent or treat malnutrition in the citizens of Amsterdam, the Netherlands, Europe, and beyond. So with that, I would like to introduce Professor Lundqvist, who is the chairman of the European Nutrition for Health Alliance. And Olle, you dedicated your scientific life to nutrition. And I'm sure that through all your discoveries and your implementation protocols, etc., you saved many, many patients after surgery. So please join me in welcoming Professor Lundqvist.
Well, thank you. Thank you for that very nice introduction. It's great for me to be here again and to see so many familiar faces who have all been with us on this journey to improve nutritional care, but also many new faces. And I thought for those of you who haven't been with us before, just a few words on what we're here to do. It's about working together. That is really the key, because we need everybody to see the same problems and to find how each and every one of us can help to move things in the right direction. Be that somebody who's working very close to the patients, but also somebody who is very far from the patients, a decision maker in the EU, for example. So the way that what we're embarking on is really translating the knowledge we have from the science into real life practice. That's what the hardest thing of everything. All of this, but it's also the most important, because if it doesn't happen on the floor, it just doesn't happen. And that's very important to remember. So the way that we have been looking at this in order to get to the policies and the decision makers, the people that are the farthest away, we believe that it's important that we help them to see what is going on. And the way to get people's attention is to embark on a roller coaster, if you like, because we need people on the floor in the different countries to make sure that they can get some people in their own countries at the EU level to start talking about this. And we've seen many examples of how that has been happening. And when several delegates from several countries start to talk about the same thing at the EU level, then all of a sudden it becomes an issue, and then decisions can be made, and then it will be rolled out to all the others. So this is a sort of a continuous circle that goes back and forth. And that's how I think we have been able to, together, really move things forward. So the alliance is really an alliance of a lot of different people that get together and form teams. All the stakeholders in every country, we want to get involved in forming what we call optimal nutritional care for all teams. And this is just a few examples of different teams around Europe, and you can see that over the years since we started this, we are now covering just about every country in Europe. And the last one to join, we're very happy to see that Hungary is now coming on board as well. So that's a great step forward. And it's about sharing good practices. Once we have figured out a good way to do something, we should share it so that others can use the same methodology and perhaps tweak it a little bit in their country, but use the same kind of experiences so that we help each other to do the right things more often to move forward. And I think we're making impact, actually. And because we have been able, over the years, to change the policies at the EU level, we have been able to change the policies in many different countries. And we're still moving on the same agenda forward. But it does take everybody on board. So today's program, I'm very happy to see that we've been able to get together and meet again and have a whole range of fantastic speakers from different parts of society, all with a stake at what we're talking about, making sure that our elderly, our frail, and our patients really get the proper nutrition that they need. So we're going to start off with kicking off the session here by inviting Marianne van der Schuren. She is a good old friend of mine. She's been at it for many years. She's a professor of dietetics at Wageningen University. She's done a lot of very important research in the field, and I'll just hand over to you so you can give us the start of this important meeting.
Can I have your?
Yeah, of course. That one you need.
I need that one.
Okay, so a big hand for Marianne.
Well, thank you and welcome to Amsterdam. As always, the weather in Amsterdam is beautiful, so I hope you enjoy the sun. It never rains in the Netherlands, not anymore. So I really hope you enjoyed the walk along the canals. For me, as a dietitian, I have been asked to present on policy, which is difficult for a dietitian working in clinical practice, a scientist, but I will try to do my best. I work at Wageningen University, at Han University of Applied Sciences, and also at the Dutch Malnutrition Knowledge Center for Malnutrition. So, talking about malnutrition, what are we talking about? I was in Israel this spring in the Haifa Museum of Art, and I saw this picture, and I thought this perfectly reflected what we're talking about. The picture you see here represents the two major challenges we are facing. Obesity and underweight, both within the construct of malnutrition. It's good to know that the underweight lady, she is the artist. She suffers from severe anorexia nervosa, and she really suffers from underweight. And that's why she made this photo of her nutritional challenges. So in fact, I could finalize my talk now, because, well, I have addressed the two major challenges, but I have decided to move on a bit. So my talk is going to be about challenges that we're facing right now, and also about opportunities, because there are lots of doors, we can knock on those doors to get nutrition on the platform. So talking about the challenges, it has been addressed already by Mireille. Our aging society is a major challenge. I'm not sure that you can see how the society develops, but for sure we are facing a large group of aging people living at home for a longer period of time with many comorbidities and chronic diseases. You can see that the graph is really, instead of this form, it's moving that way. So this is one of the major challenges. And this graph represents the number of chronic diseases within the older population. I don't have a pointer, but in the far upper corner, you can see the oldest age group with the prevalence of the diseases. And you see that at an older age, there is an increase of cardiovascular disease, eye and ear diseases, musculoskeletal diseases, etc., etc., etc. So with increasing age, we see an increasing number of comorbidities. And of course, we are all involved in the field of nutrition. We know that this increasing number of comorbidities also comes with an increasing number of malnutrition problems. So what is the number of older persons that we are facing within Europe? This is a very simple calculation. Europe has about 500 million inhabitants. More than 90% of them lives at home, and this will increase to over 95%. And the prevalence of malnutrition, and this is really on the lower side of malnutrition, of malnourished participants living at home, is 5 to 10%. Which means that we are ending up with up to 8 million malnourished older adults in Europe soon. Actually, these are the numbers right now, and this will increase. So I have already touched upon older age and comorbidities. And malnutrition comes along with these comorbidities. And malnutrition is rather difficult to define. As a spin-off of the Manual project led by Dorothee Volkert and Marjolein Visser, we have developed this DOMAP triangle, which, well, I'm not going to explain it completely, but in the middle there is malnutrition. Very much simple, very simplified, this means low intake, higher requirements, or reduced bioavailability of nutrients. But surrounding this very strict, simple representation are the factors that lead to malnutrition. So within the green triangle, you see that there are many symptoms leading to malnutrition: low appetite, forgetting to eat, restrictive diets, etc., etc. And around that, in the yellow circle, are all the diseases that come with malnutrition. And we have to empower the professionals, and we have to empower the patients to recognize the symptoms at the earliest stage possible to be able to tackle malnutrition as soon as the first symptoms arise. Well, the next challenge is, well, actually, I'm going to that I cannot for the camera. I want to see my slide. The next challenge is the shorter hospital stay. The mean hospital stay in the Netherlands is 3.5 days now. So people move from hospital to home while they are still suffering or recovering from disease. This comes with some challenges that I will address on the next slide. So, the shorter hospital stay. We have been discussing this in the patient meeting. Are transfers well organized? Do people know that malnourished people go home? The human capital agenda. If people move home, how can we treat them at home? Do we have the staff? Do we have the medical doctors? Do we have the nurses? And also, do we have the carers and the informal network who are required to play a larger role within the care for malnourished people at home? Medical care will be substituted by allied health professionals, physiotherapists, dietitians, speech and language therapists. Are they equipped to do so? Are they organized? How is this organized? How does this substitution work? There will be a larger role for the social team and the welfare team who visit the people at home, who are the first contact people for the person at home, but they have no knowledge on nutrition yet. The patients are required to take more responsibility. But can they do it, and are they willing to do it? And then there's the positive health, the idea of positive health. Don't talk about illness, but talk about what people can do despite having an illness or despite being malnourished. Has this been adopted by everybody in the healthcare system and by the patients themselves? Well, a next challenge, also an opportunity, is e-health. Sounds good, but it is difficult because platforms don't talk with each other, not yet. There are tons of apps available for patients, for healthcare professionals, but many are worthless, and we do not know which ones have been validated and how they have been validated. Are participants willing to use these apps? We are now running a pre-dementia trial, and we see that participants are reluctant to use these apps. Also, because they do not know what will happen to their data. Is the general data protection regulation, has it been well organized? And they have difficulties using it, because they have low e-health literacy. Logging in, usernames, passwords on 3 different names, it's difficult for them. So this is one of the challenges, although e-health also offers many opportunities. Then the next challenge is the challenge of rising healthcare costs. You can see that on the lower left-hand side, that healthcare costs are increasing with almost 3% per year, and it is projected that healthcare costs will have almost doubled by 2040. So how are we going to contain these rising healthcare costs? I have been talking about substitution of care by more. I have been talking about more care done by the carers themselves, but still this is a very, very difficult problem. Why are the healthcare costs rising? Well, of course, there's the aging society. The medical technology is improving, so people live longer with diseases. The population is growing, and especially the costs for cancer are rapidly growing, more than any other disease. In addition, the costs for the treatment of women with disease are increasing. It's not what I had realized before until I read the literature preceding this presentation. Well, one of the final challenges is obesity. I started off with obesity, but especially in the context of malnutrition, obesity has some extra challenges. Because next to obesity, which is a huge problem by itself, we also have sarcopenic obesity, which is often masked by the overweight. And we have concurrent obesity and malnutrition. Practitioners not knowledgeable in the field of malnutrition do not recognize these patients. Well, the patient looks good, a bit overweight, no problem, let him lose weight. So this is really another challenge that we have to work on. Fortunately, there are initiatives, the Aspen EASO initiative to connect and to recognize sarcopenic obesity. We are starting a project soon within the Netherlands to better recognize these people. But this is one of the things we really have to work on during the next few years. Well, fortunately, all these challenges also offer opportunities. One of the main opportunities we have is the Global Leadership Initiative on Malnutrition. Worldwide, we are talking the same language at this moment. The GLIM initiative is very successful. We can now collect prevalence data. We talk the same language. We can bring our problems into policy, into manuscripts, etc., etc. So GLIM is really something that we have to be very proud of. Of course, the success of GLIM is followed up because it is such a wide success. And now there's the development of GLIS, the Global Leadership in Sarcopenia, and I hope this will be as successful as GLIM. Touching upon GLIM, the first step is malnutrition risk screening, and Harriet and I are working on identifying on the early identifications of patients, participants who are in the pre-stage of becoming malnourished, because that is where we have to tackle malnutrition. Another huge opportunity, lifestyle. We have talked about medication for years and years, and at least in our country, lifestyle is hot. Replacing medication. Be aware of your health, of a healthy living, nutrition and exercise in the first places, but also a healthy brain, sleep, stress management, social interaction, and reducing cardiovascular risk factors. Many problems are now starting to raise attention to nutrition, exercise, and these other factors as primary treatments of many diseases. So this is an opportunity that we, as the malnutrition community, have to grab. Then, of course, there are also some policy rules. The WHO has made a plan to stop obesity. Obesity and malnutrition are interconnected, so we can hop on this plan. Tommy Cederholm and the Swedish delegation are talking to the ICD to obtain a code on malnutrition, an opportunity. The Netherlands, I'm also only talking about the Netherlands concerning this point, they have set a set of rules with aims for the next 10 to 20 years. By 2040, all Dutch citizens live 5 years longer in good health. How do they reach this good health? By good nutrition. By 2040, lifestyle-related diseases, read malnutrition, nutrition, have decreased with 30%. More than 50% of Dutch citizens will be given care in their own environments. The right nutrition at the right time for the right person. And people with chronic diseases will participate into society 25% better. Only possible if they are well-nourished and well-fed. Finally, we have, not finally, almost finally, we have the integrated care agreement. Also an agreement within our country, the Netherlands, a document on healthy living and prevention, which pleads for accessible care, affordable care. Nutritional care is relatively cheap, so this is an opportunity in the home situation, with an increased role for e-health, better interprofessional communication and collaboration, so roles for nutritionists, physiotherapists, speech-language therapists, etc., with the focus on health instead of disease. And finally, we have the ENHA policy, which is about healthy living for older adults in their own environment, stimulating regional networks and collaboration between the health care section and the welfare section. So as you can see, the nutrition train, though this is what I can do with art. It's a train, and I projected some nutrition pictures in it. So the nutrition train is running. There are challenges, but there are also many opportunities. And I invite you all to jump on this train and to take the opportunities. Thank you very much.
Thank you very much, Marianne. That was very comprehensive and a good opening lecture, setting the scene. Are there any questions?
Somebody has a question.
So maybe a short question for me then. So you've been laying out a lot of, issues that are far from being resolved. So if you could choose, and I know it's a hard question, where would you start in making treatment at home better?
I would start in the community because the care is shifting from the hospital to the community. And I would start with the risk group that is growing, which is older adults. And I would start as early as possible. Don't wait until these people have lost their muscles and their weight. Recognize these people as early as possible and involve their full environment, their social work, their family, everybody in the short circle around them to deliver optimal nutrition at home as early as possible to keep them fit and healthy.
Okay. Well, thank you very much, Marianne.
Thank you.
So with that, I'd like to introduce the next speaker, and which is Mark Nuiten. And yeah, I know you're there, come up. So Mark is an expert in health economics, and he founded an international health economic network. He's an expert in economic modeling, which is really important to get an idea of the size of the problem. And he's a pioneer in the field of healthcare innovation. So Mark, thanks for coming, and I'm looking forward to your talk.
Good. Okay, thank you very much for the introduction and also for the invitation to speak here again. Like first time was last year in Copenhagen, and I enjoyed the Congress very much. And also this year, I think the organization has found again a very nice historical place, like last year, to have our sessions. So I would like to start with this very excellent presentation by Professor van der Schuren on the policy, the clinical, the epidemiology. So I would continue more from let's say from a health economic perspective. So what does it mean? And I think it's important for the value of first of all, for decision makers, it's important that we quantify what we are saying. So we have to come with figures and then convince the decision makers, payers or national institutes, governments about, first of all, what is the the burden of disease of malnutrition, the clinical burden, quality of life for the patients, and of course also the economic, what are the costs for society, and then show what can we do if we improve, if we appropriately manage patients with malnutrition by giving their dietary advice, adjust the nutrition, and of course also to show what is then the impact of improvement of the health status on quality of life as well, and what is then the cost saving. So first of all, first step is to, there it is. First step is to show what is the cost of malnutrition clinically and economically, and the second step, how can we manage it? Because if we cannot if we cannot improve the malnutrition, then of course the first step doesn't really make sense. So what I would like to do is start with a pan-European approach. There have been many studies on cost of malnutrition in various countries. Myself and my colleagues performed studies in the Netherlands, Belgium, UK, which has separate projects, separate research projects. But of course, it's not only a Dutch or a German issue. It's really, in fact, global. But today we focus on the European approach. So I'm going to present how we can come with economic assessment in malnutrition from a pan-European perspective, and by that have economies of scale by developing a core model which we can use in various countries of interest. So epidemiology, it's clear, it's increasing. The prevalence is quite high, and also it's not only in the hospital, it's also in the community setting, where especially elderly, and also, of course, the nursing home care setting. So that is important. The clinical consequences are high. It's, if you have complications in the hospital, for instance, mortality rates are improved, and also quality of life. And clinical consequences lead to economic consequences, because if you have complication in the hospital, it means a larger length of stay. So that means more costs. So there are various economic consequences of malnutrition. And then the next step is what is the impact of treatment of malnutrition? It's reduction of the complications, by that reduction of lengths of stay. It also leads to a very cost-effective treatment, as we showed previously, increase of quality of life, and reduction of hospitalization costs. So how do we start? First of all, what we developed is the field of nutrition economics 10 years ago with colleagues based on a PhD program in Maastricht. We're working in health economics. That's where it started for drugs. So we use that as a benchmark, where indeed drugs are not only reimbursed on registration, but it's really cost effectiveness and budget impact. So cost effectiveness and budget impact are key, and we're going to translate that to nutrition. First of all, very shortly, what is cost effectiveness? It's not my idea to give full course of health economics, but just to show what is the ICER, which is often mentioned, the cost per QALY. It means that you compare treatments, survival, but you translate survival into quality of life. That's more important. I mean, that's according to the theory. That's more important than survival. So quality of life is 1.5. 0 is death, and 1 is perfect health. So it means they are a little bit in between. So in the second treatment, you have 1.9, so much better quality of life, which can be because of less adverse events, of less disease progression. So you see this leads to a 4 and 4.5. An advantage of using utilities or QALYs is that you can compare outcomes between diseases. And then the next step is add the costs. So what is the cost of treatment A and B? And then you see the total cost for A are 10,000, for treatment B are 15, so it's 5,000 more expensive for treatment B, but you gain half a QALY, so that's 5,000 divided by 0.5, and that is still 10,000. So the ICER is 10,000, so you pay 10,000 euro for 1 additional year in perfect health. And in the Netherlands, we are willing to pay from 10 to up to 80,000 for very severe diseases. So that's called the threshold. As you can see here on the axis, the QALYs and the total cost of treatment. And then it's interesting to mention, first of all, that for drug evaluations, the cost effectiveness is usually 10,000 to 500,000 euro per QALY, depending on, of course, on the disease. So you're usually in the right upper quadrant, and then, but for many malnutrition, and I showed that last year in Copenhagen, in fact you are in the left quadrant, position 1, which means you gain in QALYs, more QALYs, because you reduce complications and so on, but reduction of costs. So you invest a bit in treatment of malnutrition, but the cost savings are so much offset. So in fact, you are giving QALYs, more QALYs, at a total lower cost. And that is, in fact, the dominant position. So the most interesting outcome, of course, you gain QALYs, and in fact, the payers have cost savings. So that's important to know, and it's also shown that, in fact, nutrition is relatively undervalued by payers. Then the cost effectiveness is the cost per QALY at the patient level. So you say a patient goes on this treatment or the other, what is then the cost per QALY? And of course, especially if you know there are cost savings, it's easy to make the next step to make a cost benefits. What is it at population level? So if you have 5,000 euro cost savings per patient, and you know the prevalence of malnutrition, for instance, then you can calculate the budget impact and the cost benefit at the society level. So that is an example here. So the key for application of health economics to nutrition is, in fact, you can apply the concepts used for drugs issued by organizations like NICE or the Zorginstituut here. There are no specific guidelines. The only important thing is you need to have clinical evidence which is accepted by health authorities, which means still the classic standard RCT. Yeah, thank you. So just overview of the target audiences in general for applications for drugs, but also for nutrition. You see the society level, that's really at the highest level. that is really the cost per quality. For drugs, for nutrition, it's a bit unclear. Payers, that's let's say the Krankenkasse or health insurance or district health authorities, the cost per quality nutrition, but also their cost savings are getting more important for, let's say, decentral. So like, let's say the payer organization, the health insurance company, that's really cost savings, and of course the quality of care you provide, but then you don't need to translate it into a nicer medical community. It's of course physicians, they want to see effectiveness, efficacy, but also quality of life is an important measure of effectiveness. The employer, and don't forget also that employers can be, if you take a broader perspective where you incorporate cost savings due to lost productivity, then especially also employers can have an incentive to be interested in treatment of malnutrition, of prevention. Probably this is maybe more for the at risk, where you want to prevent that patients develop a disease. And finally, but probably I made a mistake, I would have the patient at the top. But for the patient is first of all, what is the ratio between the co-payment and the benefit? But most important for the patient, of course, the benefit, and therefore the patient should not be in the position to make, in fact, this assessment between payment. It should be reimbursed fully like drugs. So that's my opinion. So the pan-European approach. So, and this is this is the approach which I'm using for more than 20 years for pan-European studies, for developing European models for submissions to NICE or TLV in Sweden or in the Netherlands. And by that you can develop very efficiently in terms of costs, but also efficiently in timelines. You can develop one country, a core model for Europe, and the advantage is that there is consistency because you use one core model, you develop it, for instance, for the Netherlands or for England, and you define then your model structure, reflecting the most relevant treatment patterns. And of course, you can do country-specific fine-tuning. If, for instance, one treatment pathway is not relevant, you have a dummy and you put it at 0. You use data sources, and there you distinguish country-specific, like costs, and more international data about clinical data. And in this case, I would suggest a European advisory board from different countries, that you have a validation of the core model, data sources, and assumption. And as I said, the advantage of this approach is that if you use the model in Netherlands or Germany, you have consistency in this core model, so that increases also the credibility and the comparability of the results. So this is in fact the structure, a potential structure of such a core model. So it means, on the one hand, the clinical consequences, including mortality, and on the other hand, the economic consequences resulting from that. So these are the key, let's see, the key determinants of such a model, where you have the settings, which I mean hospital, home care, ambulatory, of the community care. What is the prevalence? What is the comparison, which means how do you compare it? What is the current treatment, the standard care, or what should be the optimal treatment according to the guidelines? So if we can benefit also there, that's so the model can not only be used to assess impact of ONS or medical nutrition, but also the disease management. So, for instance, by increasing screening tools, so you identify more patients, so by that you can treat more patients and avoid the costs of malnutrition. So it's also a kind of disease management model, regardless of the underlying treatment. The steps is indeed you incorporate the clinical and economic consequences of malnutrition, and then you look, for instance, at the impact of malnutrition, and you incorporate cost of management of malnutrition. So this is the setting. Of course, it depends on the setting. So I distinguish 4 main settings, like the hospital, the community, and the nursing care. And these from the literature are a number of selected, identified clinical parameters on the left side, and on the right side the economic measures. So this pan-European model contains, in fact, all these parameters, and then you can identify for each country which is for the Netherlands or for Germany the most relevant parameters, depending also on the healthcare, the financing of the healthcare system, and the perspective of your analysis. So for instance, at the right, you see the medical costs, but in the Netherlands, we have the societal perspective. So if possible, you should, if relevant, indirect costs to lost productivity should be included, as well as any non-medical costs, transport or medical home modifications, for instance. This. Just to go over. Yeah, this is important from a practical point of view. So you have always to make a distinction in health economic models between country-specific data, that's always the costs. So because costs depend on the financing system of the system, on tariffs, specific tariffs. So you cannot use exchange rates because that's not correct. So it depends on the finance system. Also the clinical guidelines determine the costs. So that is really country-specific. And of course, usually for drugs, but also for malnutrition trials, you can use international data. Of course, it's need a validation, but in general, from Western countries, you can use clinical trials and apply them data from to the Netherlands or to Belgium, for instance. So that is really country-specific, international data. And of course, it's always good to have a local validation of that. And therefore, I also suggest a national advisory board. And then utilities, which are not mentioned here, that is more a bit in between. Ideally, you should have country-specific, but usually you can use international utility data. It's the quality of life of the outcomes, the sources, clinical trials data, the international trial population statistics. And as I mentioned, Delphi panel is crucial to have a validation of the assumption and handling of the data from the sources, to estimate missing data in case there is limited information. But I think the validation, especially the clinical validation, also because of the definitions, for instance, what is at-risk patient, so that really needs country-specific validation before you move to the model development. And then important is, this is more general, so a pan-European model. First is the structure of the model, the methods, which is a cost-benefit, cost-effectiveness, and the assumptions and the data sources. So it's always a matter of optimization between data sources and assumptions, because in no model you have all the perfect data for your model. So it's also always a challenge to optimize, and that's a matter of experience and also know how assessment authorities look at your dossier. And if there's uncertainty left, it's important to use scenario analysis, sensitivity analysis. So the conclusion is, first of all, a European approach for the assessment of the clinical and economic assessment of malnutrition and to measure the improvement of malnutrition for key decision makers. A pan-European approach is recommended. It's first economies of scale. But that's more for the funding of the project. But more important, consistency approach in your model between different countries, so you can make a comparison of the outcomes between the different countries, which increases the credibility. And by this I would like to end my session. Thank you very much.
Thank you very much, Mark. I'm going to give you just one quick question, if I may. How much do you estimate that we could be actually saving for society by doing optimal nutritional care? Do you have any ballpark figure? I mean, we're far from best practice today.
For instance, in the Netherlands, you can talk about 10, 20 million per year, depending on of course, on your underlying model assumptions. But it's really substantial, because cost of if you talk only about cost of treating malnutrition, it's relatively low compared to a per diem charge of €500 per day. So you can see that and that's why also in the cost effectiveness diagram, which I showed, contrary to drugs, indeed, new innovative drugs are always higher priced and also always lead to higher costs, but they also lead to higher qualities. And by that, you can justify the higher. But as I said, in nutrition, the cost is relatively so low compared to the other costs, like the per diem. that you, in fact, you are cost saving. So that is, in fact, no-brainer. Should be a no-brainer for decision makers. Yeah.
Well, thank you very much. That was a very important message. So thank you very much. So now we're moving on to the most important people that we're all engaged in, and that's the patient. So it's my pleasure to invite Manuel Arellano from Spain, Navarra, and he's going to talk about the role of the patient advocate in the European debate. And he is a patient advocate. He's very much involved in the Spanish Kidney Patients Federation and the Spanish Platform for Patient Organization. My pleasure to see you here, and the stage is yours.
Thank you. Thank you very much for invite my organization in representing behalf of the POP. Maybe you have hear about when you do POP, there is no stop. This is the name of my organization. There's no right, and the EPF European Patient Forum. I want to share with you what are the patients. The platform of the patients in Spain, the Spanish patient platform for the patient organizations, is this. We are an umbrella from 35 national organizations who represents 1,540 associations with almost 1 million of patients associated with more than 12,000 workers and more than 60,000 volunteers. And at level European, in the EPF, there are 78 organizations who represent 150 million patients in Europe, around 19 countries. This is a huge data. And what I want to tell you this morning is talking about that. This is our concerns. Early detection. Nothing you don't hear in this morning. Before me and after me, you are going to talk about this. The first one is the early detection and nutritional assessment. We think for the patient advocacy, it's very important that to identify properly the needs of the patient, the needs of the nutritional status of the patients, and have the correct criteria to assess the tools you use to identify. In primary prevention, for us, is the first step. Maybe in Spain, more doctors in primary care leave or send the patient to the hospital. And maybe it's people with obesity only and with diabetes. So it's to the hospital. Why? Maybe in the primary care is the way they're going to need to be attended, and who prevents the possibility of complications, comorbidity, because it's best to prevent than cure. This is very visual. Second point is health and food education. We must identify the risk in the food. In 2009, I was like Schwarzenegger, more or less. But due to a malnutrition risk before a surgery, I became this. It's not the same. It was a size M, and now I'm an XL, XS. So 10 kilos. I lose 10 kilos. 10 kilos of muscle, because I'm bones and skin. I'm nothing more. So we need to identify the risk, and this is beginning of the diagnosis. Diagnosis is the first one. with the prevention. And we need to exchange patients with professionals our needs, because we are the protagonists of our lives. We know what we need, what we want to be, and this is your business. Try to help us. Not do what you want we to do. No, it's what we want to do. You need to support us. It's not different. This is the way. So maybe for educate, starting in the decision maker, in the micro level, in the consultant. Education with the patient, with all the information, clear, accessible, completely, information completely. This is the starting for education. Because patients needs to be co-responsibility with their own disease. It's not the disease of the doctor. The doctors doesn't treat disease. Doctors see people. I am a person. I'm not a disease. I'm a person. Maybe this is for God, for a lot of people. Don't forget this. If I take care of myself 8,710 years, 10 hours on a year, I think it's all the year. If I take this time, I take care for me, not only the 10 hours I'm in your consultant, maybe my health is improved, is better. And the relationship with the doctors maybe could be better. So take care about this. Measuring and outcomes. This is very important. I usually said that quality of life measures is like start walking 10 minutes. How many steps did you do in this time? Okay, that's right. Maybe it's a measure, but for me, as a patient, what is the importance of that for my quality of life? No one. So maybe if you ask me what is important for me, maybe you could select the important things for the patient. A lot of things, a lot of measures may be important, they are important for you, but you are treat the patient or the disease. If you want to treat the person, maybe you need to start with the prompts and with the prems. Because it's not the same. Some measure is measure. It's nothing. Nothing more. Measure is measure. It's very different than the impact that the measure has in me. So think about it, because it's your change. We need to propose. We need to be educated. But it's your first movement. Count with the patient. The patient, there are doctors in public health that say that the patient is the resource less used in the health community. So let's improve information and accessibility. If we don't understand what to do, what do you want we do if we don't understand the information? Translate to the common language, to the popular language. Before I was talking with Nuria, maybe? Nuria? Yeah. Malnutrition. If I say to my mother, I have malnutrition. What? What is this? She don't know. Because I have underweight. It's compensable. Malnutrition? Not every people could understand this. And caregivers and relatives and your environmental, social environmental and familiar environmental needs to understand and be part of this. Because the disease is not only yours, it's in your family, in your... This is visual. I think Peppa Pig. Who don't know Peppa Pig, please. Don't know Peppa Pig? You don't know Peppa Pig? Go out. Oh. Mi amiga, my friend Peppa Pig is in Spanish, but and you know the other imagine, the other picture? Maybe not. It's in France, it's in Spain. It was once upon a time, the life, the people, the history, about different things. But in this area, talks about health, and talks about health for young people. And yeah, talks about health to young people to explain what is blood, what is the function of blood. And it's with picture. It's very simple. With imagine, we need not to read. It's more visual. We understand the visual thing. Everyone understands visual thing. You go walking on the street, you see the tourist signal. They are visual. For Chinese, for Muslim, I describe these two countries because the signature is different, the letter is different, but they don't need the similar letter. This a picture, okay, place, cathedral, easy. Let's use accessible information. The access is fundamental. Some patients haven't access to nutritional care because they have no diagnosis, because they have no how to do it. If we have a special nutritional care service, maybe we can provide support to the patients. And I mean pharmacy, and I mean nursery, and I mean doctors, and I mean psychologists, and I mean nutritionists, and I mean social workers, and I mean, if you don't have it, patient association have it. So maybe it's another point to enjoy, to look cooperation, to work together. And we need to adjust, to adapt the needs of the patient when the circumstance is different. Now I'm with one circumstance, with one health problem, but maybe 1 year before, 1 year after, excuse me, I have another problem, another disease, another point in my life. I need to have some adaptation of the information. I want you to show this video, please. No.
Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones below stairs, sir.
Why, I was planting my petunias in the potting shed.
Constable, arrest Lady Smythe.
But how did you know?
Madam, as any horticulturist will tell you, one does not plant petunias until May is out. Take her away.
Sorry, madam.
It's just a matter of observation. The real question is, how observant were you?
How many? How many? 1, 2, 3? No one? 0? Do you want to see the 21 change? Let's see. Please.
Action. Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones below stairs, sir.
But I was planting my petunias in the potting shed.
Constable, arrest Lady Smythe.
Do you agree? Where are your patients? Do you have contact with the patient association? Because if you don't see your patient, you don't know what they need. And if you don't know what they need, you do what you think they need. But maybe it's not the same. This is a campaign, a UK campaign, to stop the biking, the riders in the street, because there are a lot of mortality of the biking in the roads because of the traffic accident. It's a campaign. It's nothing for nutrition, but I think it's very, very, very important to see this. Digital transformation, we see the problems, interoperability. There are a lot of problems. One of them is the difficulties for some kind of people. All people, but not all people. For me, it's difficult. I know, I look like 25, I know. But I have 42. Okay, 50. I have 50. For me, there are some difficulties from any kind of digital devices, digital information. We need to make accessible. This is a challenge for us because we have no information. We have no access to a lot of information because now everything is digital. Telemedicine. For what? Quickly? We need to stop to treat like a normal consultant with the time schedule, with the soft, with the visual. Visual is not visual. No verbal. Language is more important. It's very important. Touch is very important for us. Look to the eyes is very important. And now all the digital devices let us to take this information. Active patient participation and empowerment. Excuse me. For us, this is the most important thing. And for you, too. And you don't know. But I hope after today, you discover that you need patience. Because I'm a protagonist of my life, of my disease. And if you treat me, maybe I'm happy. And when I was happy, my disease is not that worse than when I was ugly or sad. So please take in count to the patient, because we are the final beneficiaries. If you see the car campaigns, the Volkswagen, Seat because it's Spanish, Mercedes, what you want? They ask to the final consumer what they want. Why in health there is not the same kind of question? Why we don't ask to the final user? Why? We are all together in the same boat, and the water is not easy, it's not calm. It's very difficult. The environmental, we move. So we need to be together, stay together, go together, everyone. And the patient organization are crucial. We can create community for the patient. We defend, we advisors, the right of the patients. We give visibility to the patient. And we could support you in your investigation, in your research, what you want, because I'm not me. I'm almost 1 million of people in Spain, almost 150 million of people in Europe. It's not me. It's my vision, but it's not my personal vision. It's the vision of the patient. So we promote the importance of the caregivers. The change...
Manuel,
I have to finish this. I think it's the last three slides, and I finish. Okay. I promise. More or less. More or less. The chain is stronger, but the chain is broken where the link is weakest. The weakest link is the point of the chain is broken. And which is that point? The patient. The patient is not in the center. The patient is one point of view more than the other people. 3 things. It's not European legislation because there is no applicable European legislation right now, but due to a very important thing, the Vienna Declaration. It's great. It's great. But you have not the point of view of the patient. There is no patient. So you need to include the patient. Every policies, every legislation is about food safety, otherwise obesity, otherwise. Patients, when I put patients, is EPF. EPF calls for a lot of things, but guarantee equity, justice, fundamental rights for the patients. This is the last one. I put some recommendation of any kind of legislation. In Great Britain, in UK, because of Brexit, some patients have no access to foods and device. As I speak with I forget your name, excuse me. NICE directives only face to nutrition and malnutrition for chronic patients. But there is directives, there is not reality. In France, they speak on prevention, but no more. In Germany, with the Federal Institute of Risk Assessment, there is no specific rules for chronic condition. In Spain, we speak about prevention in now strategic. And we could go on. The most important, and maybe is the guideline, the green light is the Netherlands, because the National Nutritional Guideline is a case of success. So copy this idea. We could go on out, but the most important thing that this is inequitative. And this is the summary that the things I have talking about. And only stay there. I finished my speech.
Thank you so much,
Thank you,
Manuel.
and excuse me for the time.
And I like how you totally ignored me standing here.
Because I
just
become nervous if I see you.
Yes. So Manuel, thank you so much for advocating for patients, and I think you have a very, very strong message to us, healthcare providers, that we should really take advantage of the experience of patients to improve the care for them. So thank you very much.
Of Health Disparities and Person-Centered Integrated Primary Care at the Radboud University Medical Center in Nijmegen. Welcome.
Good morning, everybody. I'm very glad I got the opportunity to speak here on behalf of the European Forum for Primary Care. I can imagine that you are getting a bit hungry and also a bit tired from all the lectures and the very interesting and relevant information you received up to now, but I can reassure you, as I'm the fifth in the line, most of what I'm going to tell has been told already. So that makes it, I can go quickly. I would like to address, as I'm saying, I'm the chair of the European Forum for Primary Care, and that's a forum that aims to strengthen primary care, affordable, accessible, good quality primary care for all in Europe. And that means that we acknowledge that we cannot do it by one discipline, not by doctors alone, not by nurses alone, not by whomever alone, but only together with all professionals and with the patients as well. And we have received a very good talk about that from Manuel. Thank you very much. Also, the European Federation of Associations of Dietitians is member of us, and that's how I came up here. And I will talk about the need for continuity of nutrition care across the borders of specialist hospital care and primary care, and how we should make it person-centered and integrated so that all the disciplines are working together. Why is that important? Well, that has been discussed already. The population in Europe is getting older, and the healthcare costs are rising in all countries. So we need a shift from hospital care to community care, to the people's homes. On top of that, there are technological, improvements, I think mostly they are, that makes it possible, more than when I started as a GP 40 years ago, for instance, to treat people at home with enteral tube feeding, for instance, or people with cancer who are have a more prolonged life expectancy, but often with difficulties, with also nutritional difficulties. So that's where we have to go to the place where the people live, and they pass most of their time there. And whatever your home looks like, whatever your situation is, it's different for every patient. But food is always one of the most important aspects of daily life. And to be honest, it was very interesting. The last talk also about the lack of awareness of GPs on food. I fully acknowledge that. And from all the 21 changes, I didn't notice one. So I think indeed when you don't know there is something, you don't see it. And that's really the case in when we as a healthcare professional go to see a patient, and we often don't know how he lives, what are his circumstances. So we need to do this together. We need a strong interdisciplinary primary care, especially as most of the patients who, that's already mentioned also, suffer from not only one disease, but of multimorbidity. Over 1 in 3 of all patients suffer from multimorbidity. More diseases together, so they need more different treatments and they need more different healthcare professionals. So when we are talking about person-centered care, what do we mean by that? And I think it also has been mentioned by Manuel. It means that we are not treating a disease, we are not disease-oriented, but we are goal-oriented. The goals of the patient, what matters to the patient, that is the thing that should lead our treatment and our approach. And that means it's driven by the needs of the patient, the values of the patients, and that can be totally different from sometimes the disease. So sometimes as a doctor, you would say, well, it's most important that you get your protein up and you should take this or do that. But when the patient says, well, but I really loathe this drinks, or I really, I don't care, I really want to go and go to a dinner with somebody and eat there what's on the table, then that can be more important at the moment. That means you can only do this, meet the needs of the patient, when you really engage the patients and engage them also in your research, in your development of interventions, using PROMs, PREMs, etc., or other measures, because they know best what matters to them. And we know that such a person-centered approach really makes a difference. It's not only pleasant for the patient, but it also leads to far better health outcomes in terms of, for instance, when you talk about diabetes patients, better levels of glucose in the blood, less complications. When you look at surgery, it has better outcomes. Well, it's in every field you see. It leads to better outcomes. It leads to more equity, that each patient gets the treatment he needs, and also to lower costs. I once again want to stress the importance of the patient involvement, because, and I know that sometimes doctors are not so much aware of that or don't think that. I think the dietitians will be better in that respect, as nurses are. Of course, the patient is the expert on his own body. And especially when it comes to food, we all know we have all particularly preferences, dislikes of food. We are all from different cultures, and in food plays an important role in culture. So you have to know what is the preference, the culture, the customs of the patient, not only in preferences food, but also in food preparation and in food, how you eat, with whom you eat, etc. I'm obviously not a dietitian, so I was reading before this lecture, and I was very pleasant, well, not surprised, but also I was glad to see that also in your own standard, the notion of person-centeredness is crucial in your standards. And all these are important aspects of a person-centered approach, because, as is mentioned before, that entails a lot. Of course, it is about communication. It should be understandable, it should be acceptable, it should suit the patient you see before you. You cannot do it alone, you have to work together. You have to look at other issues than only the medical stuff. So how do you live? Do you have enough money? Are you worried? Do you live alone? Do you have a family? Etc., etc. So it's a lot of good stuff in your standards about that. So this altogether brings more people with complex diseases which need complex dietary care at home. That's one issue. And besides the whole issue of the malnutrition in elderly people, and the broad definition of malnutrition is really also something we should tackle together. But especially when you look at the people with complex diseases who are being treated in hospital, then we have a special challenge, because we see as GPs, and I know from primary care dietitians here in the Netherlands, you know perhaps that in the Netherlands primary care dietitians are very common and very well valued. They often receive no information from the hospital when a patient has been discharged there. So when you want to really establish continuity of care, through the whole chain of treatment, you really need specialists, medical specialists, dietitians working in hospitals to provide the primary care professionals with information, and of course vice versa, because they will need also your experiences. So looking at the circle of care, you see that the continuity of care basically addresses three important issues. The information continuity. I will go on talk about that a little bit more later. That's very important. It was already mentioned, we have to know from each other. Thank you. I also want to flag up the importance of relationship continuity, because that's something we really know a lot about. That for patients, for us all, it's very important that you are able to see the same healthcare professional, the same doctor or the same nurse or the same dietitian as much as possible, because then you can build a relationship of trust and mutual understanding. But in this aspect, when we talk about interprofessional collaboration, the first thing we have to do is get to know your colleagues. And there are many good examples of the dietitians working in primary healthcare centers, for instance, and having regular meetings with the whole chain of treatment for patients with complex diseases, together with the secondary care. And we are now also, it was already mentioned before, students are learning interprofessional communication and collaboration skills, because it's not always very easy. When you look at information transfer, there are some very nice examples. This is sometimes difficult because we want to have the information from the specialist, from the primary care, and also from the patient and his environment, because they, especially when it's about nutrition, they will know best what's going on and what's possible. And there are a few nice examples. I just want to mention them. In the Netherlands, for instance, we have the patient passport. It is still a written, but you can also make it online, booklet the patient takes with him or her. She or he writes in it important issues. The specialist will write in it, and the primary care dietitian and doctor. In the UK, there is the home and enteral nutrition service that really has established a good continuity of care between specialists involved in enteral feeding and primary care professionals. And another example is in Estonia, where 98% of the patients have access to a patient record that's covering all the different disciplines. So specialist care, primary care, and it's now also evolving more to include physiotherapists and dietitians. So these are a few examples, and there are lots more that we, working together in Europe, can really establish this continuity of care for nutrition between specialist care, primary care, and vice versa, if we want to learn from each other, if we listen to each other, and I think a conference of this is an excellent example of this. Thank you.
Thank you. Thank you very much. Excellent talk, excellent timing, which is always appreciated. We're going to ask the other last two speakers to come back to the stage, because now we're going to have a bit of a panel discussion. So, Manuel and Marjolaine, yeah. And I'm also going to introduce a couple of more people who we will be asking to the stage, and that's Rocco Barazzoni. He's the president of ESPEN, the leading clinical nutrition society, so you can have a chair each here, either any way you want. And also, of course, Annemieke van Ginkelreeks. She is honorary president of IFAD, the dietitians organization. And we are also going to introduce two leaders of this debate, and that's going to be Robert Green. He is Global Oncology Patient Advisory Board. He's working with them. And we also have Arthur van Zanten. He's from the local Penn Society in Espen here So we're going to hand over to you. Please, the floor and the stage is all yours. We're going to let this, just one housekeeping thing before. We're going to run a little bit over time. We'll give you 25 minutes.
25.
I'm sure we
Thank
will.
you very much.
Please.
Okay, thank you very much. So we will have maybe a debate or a roundtable meeting. We try to get as far as possible solving the first question, or maybe the main question. What are actionable recommendations to improve the continuity of nutritional care in our health systems? So, well, that's a big challenge to solve this issue in 30 minutes, but this esteemed group of people must be able to give us some guidance on where to start. And, well, I hand over now to Robert maybe to maybe I launch the first question and then you respond on that. So the first question could be, what are the main challenges currently faced in creating opportunities to ensure nutritional care for European citizens? So it's a very broad perspective, but what are really the main perspectives? So maybe you can start, Annemieke.
Okay, thank you for having us here. I think one of the main challenges is the transfer, and I think it is mentioned already, from hospital to primary care and back to it. I think that's one of the main challenges. Of course, also raising awareness is something. Patients should be aware that nutrition can help and have impact on quality of life. So, yeah, I can mention one, but these two, I think, I wanted to address.
Thank you. The others like to want to respond on this? You have additions to this ideas?
I have an addition, and that was also already discussed a couple of times, that there are many risk factors for malnutrition. And focusing on the risk factors, then you can really do something. Because those are people with a high risk. You can detect them, you can start preventive measures, and that's not being done. Only when malnutrition is being recognized, then the whole nutrition care starts.
Maybe Rocco can respond to that, because I'm an intensivist, so I take care of patients who lose 1 kilogram of muscle mass per day in the ICU. And we've noticed that after discharge, the intake is about 50% of what it should be. So should we measure all the patients from the hospital or in the community, or focus more on risk groups to identify those who maybe can best benefit from that? So it's a matter of, well, nutritional assessment in specific groups, or should we measure the whole European population above 60 years of age? You want to respond, Rocco?
In a way, thank you, and good afternoon, good morning, everyone. Thanks for the invitation. I think in a way, it's almost obvious to say that it's better to stratify. It's always better to stratify, but we are talking about clinical practice and setting, of course, the best practices that are cost-effective and reasonably implementable. I think that we have all the, not all, but maybe we have made great progress towards recognizing and proving and providing evidence that nutritional care works. So I think that that's a more technical, professional part, which I think we can take care of. What I really also believe, and this kind of meeting is one great example of that, is that we really need to raise awareness and talk about these things among ourselves and also outside of our community. Because we have the evidence, we have the, I think, the arguments to convince, but maybe communication is not good enough or effective enough. So I hope I replied to your first question, but I also want to make the point that I think we also need to work on awareness, maybe political communication basis.
Robert, do you want to respond and maybe also ask the public also?
Well, actually, it's great hearing what you just mentioned, because one of the things that we actually discussed this morning in another session was, what about the group that has no awareness at all that they are at risk? So there's this group that, even though it's difficult to reach, but still easier to reach than the group that has no idea what they should be looking out for. Is that something that also requires attention or not?
I do think so. I'm wondering, is there a dentist in the audience, for example? We know that people with oral health problems are a high-risk group. So if we make dentists aware of that, and they see a person and they talk with this person during a treatment, well, not during maybe, that's usually tough in a dentist's office, but before or after. So I teach at the dentist school in the Netherlands, I teach them about malnutrition. So I think those are the steps that we need. So it's not only the doctor or the nurse, it's a much bigger group that can be involved.
I totally agree. I admit.
And then you can stratify.
Yeah, I follow up with Maria. So I was an associate editor, or I am, for clinical nutrition. And then I found out I had to review papers on dentistry and nutrition. So first I was completely shocked. Is this the right journal? But you're totally right. This is a very important issue. Maria, you'd like to respond?
Yeah, I first want to respond to the major group, I think, of people who are not aware about nutritional problems, malnutrition or whatever, for all different reasons. And I think that would be indeed important. And I think besides of publicity campaigns, also there the primary care physician can play a role, because generally he knows people and he sees especially the most vulnerable, whether it are people who have low literacy or people who cannot read in the language we address, or whatever reason they are not aware. But then it starts again, indeed, with raising awareness among family physicians and nurses. I think that would be very important. And then, of course, always stratify. To be honest, there's a lot of evidence that at least screening in primary care is only for very few conditions sensible, because we deal with the majority of people who are not afflicted by it, but making awareness and knowing to ask what questions. And for instance, now we know that there's something we have trained in, that dental problems in elderly people are so huge. They often don't brush their teeth anymore, or not very well, or well, whatever. So in addition to that, we could also ask our dietitian in the community, how can we, what 4 questions should we ask here to people to get an idea about their nutritional status? So I think that would be helpful.
Yeah.
We are talking about citizens.
I'm sorry?
We are talking about citizens, not only patients.
No.
So about European citizens. Yeah. There are a lot of citizens who doesn't know they could have some risk to develop this kind of disease. And another point is we need to be transversal with the dental, but today is a World Kidney Cancer today. There are any nephrologist here? Nephrologist? No. It's the same, because we need to spread that information in all kind of specific topics or departments who treat with people with diseases, with these kind of diseases. This is transversal.
Yeah, Rocco would like to respond.
Yes, I think that I totally agree with what has been said, especially about dentists. The dean of my medical school is a dentist, and we try to have this kind of discussion. So sorry for the personal note, but maybe what Robert meant was maybe the patients. And I would like to ask, to take the opportunity, maybe we can also continue the discussion later, to Manuel. Do all the patients really are aware? I mean, I think the answer, unfortunately, is not. But what do you think about awareness of patients, about the importance of the nutritional status? And because, okay, if you have intestinal failure, you have home nutrition, that's relatively easy. But patients in the renal field, in the cancer field, do you think that there is awareness there on the importance of malnutrition?
You know the answer. The answer is obviously no. Obviously.
That's maybe the most important.
Yeah, it's the most important. But I told before, patient association needs to educate, and capacity building with the patient in order to change this way of function of the patient, because in renal disease we need to take care about nutrition.
But now we have an interesting point of view and maybe a slight debate is starting now, because Maria said the GP should do it. They know the family physicians and so. And Manuel says, well, no, we have to educate the patients, so they have to ask for it. So who is actually responsible? Because you're looking at this topic from a different perspective, or should the dietitians do it, or the geriatricians, or the nutritionist? Who is responsible for improving this problem? Probably all, but where do we start?
Can I say
Opinions?
something? Because
yes,
I think just like obesity is a multifactorial problem and a multi-sectoral problem. So I think also the approach of malnutrition is multi-professional and multi-sectoral. So we don't have to do one thing or have the responsibility by one, because and next to that, I think it stays important to get the referral to a specialist who knows something about dietetic and nutritional care. And the patient should go there, but also the patient should be very proactive in approaching us, because there are many research conferences, but no patient is there. So let we invite them and really talk about the issues to get more understanding on what they need.
But this morning we also heard about the health economics impact, and that maybe €1 spent in nutrition improves like healthcare cost or societal cost by a multi-factor. So is it like a European community issue? Is it government policy, or should it only be driven by healthcare experts or patients? So where do we start?
If you think about costs, I think primary care is undervalued. And the governments don't want to take money for instance, extra consultations for GPs or for dietitians or for physiotherapists. And if you look at the cost of hospital care, it's much higher. So maybe we can work together more, but also on this cost effectiveness issue.
What about, I just have one question.
Yes, please.
What, do we need to have some sort of accountability? Because the question that you asked, very important, is whose responsibility is it? Is it across the board responsibility of each of the stakeholders? But when you come to accountability, how do you implement that?
I think it's in the essence, it's a public health responsibility, and it's, as Annemiek said, it's certainly a multi-professional, always together with the patient and the people who are not patients yet together. But I think in the end, it's and that's also how it's looked upon in the Netherlands as a public health responsibility. The public health authorities measure all kinds of things. They should take more on nutrition in their surveys, because they look at overweight, underweight, financial lack, etc. But there are very few questions about nutrition in it. And so then you could make per community a plan together. And for instance, we have very nice examples here also in the Netherlands, in which I was involved, and a dietitian, and we went we were invited by a mosque to talk with the people there gathered for a religious meeting on diabetes and on healthy food. And that are the opportunities you get to reach the people you usually don't reach. And they had lots of questions. And we organized a supermarket safari, for instance, to go with refugees who cannot read Dutch, and we go to the supermarket and we show them how they can see what is in it, in products, and what that means, and what they usually take, and what perhaps alternatives would be. So there are lots of examples where with a more public health interdisciplinary approach you can reach a lot. And besides, indeed, primary care dietitian should be, I think, more incensed. So in the Netherlands, primary care, the dietitians can get reimbursed by the health insurance, but only for a very few indications, not for general things. So.
Please, Rocco.
Of course, I agree on the importance of primary care, as we are talking about accountability, which is, I think, maybe a strong word, because at the moment we are talking also about awareness. So it's difficult to say, okay, who is accountable for something that is not entirely recognized, and that's unfortunately the challenge. We are not diabetes, we are not heart failure or heart attack, and so on. So, but I think that if we speak on a more formal level, of course, policymakers should be convinced, because if we have recognition, if we have a sort of a more clear, let's say, scheme where malnutrition has its role, and we will talk also tomorrow about diagnostic criteria in ICD and this kind of official recognition, then we have to push to go there. In a way, it's a vicious cycle, because if we don't create the critical mass pushing for that, maybe the policymakers will not be willing to respond. So at the end of the day, I think that meetings like this, where the different stakeholders are trying to create some synergistic actions, are maybe the best response. And then everybody is accountable in a way, and we try to push for official recognition.
So maybe, Marjolein, one of the big problems is the group of patients growing older and older, and that's a target group for malnutrition. I know that many governments are really worried about this with pensions, retirement, costs of healthcare and so on. Is this maybe an entrance to the governments to have the geriatricians help us to make the awareness among this group and then spread it to other risk groups?
I think geriatrician, of course, can play a role. But I think in the Netherlands, the most vulnerable people at home in the Netherlands are the people receiving home care. And that's such an important care level where I think a lot more can be done. So if, for example, there would be mandatory screening for malnutrition in home care, I think we will recognize a lot of older people at risk, can look at what causes this person to become malnourished, solve those issues like dental problems or other problems. I think that's really a missed opportunity. And I know the government is worried about this because people live longer at home, sometimes even with some cognitive impairments. So this is really a worrisome group. And as soon as you have an informal carer, maybe you're sort of doing okay, but as soon as that person is lacking, then the only person sometimes coming in a person's home is the home care nurse.
You all mentioned actually that education and communication is a problem. And also, like in home care, if we can have the home care staff members knowing more about malnutrition. So what is maybe the best strategy in your ideas to improve knowledge, to improve education among all these groups of, well, healthcare professionals that help our patients? Where should we start?
Can I add something to education and awareness? It's also about implementation, because we have a lot of good research going on. Also, in the Netherlands, we have the Dutch Knowledge Center of Malnutrition. They have very good care paths. Why aren't we using it?
So the information is there, but it's a matter of implementation. And that's also the same, because we focus a lot on awareness and screening, and so you identify the right patients, but then the next step is what makes the change? And there should be some nutrition involved, and how can we be successful, and maybe also for the patients, because you can prescribe some of the interventions, but is it really taken? Does it make a difference over time? And I think the knowledge over there is much less, so that's more change implementation programs. So what is your ideas about that, the success of our programs to make the difference in the end, after we have identified the right patients to do this?
And can I add a second question to that? Can you also think about the role as a patient advocate? Is there a role for patient organizations to go beyond? Because currently we look at patients, and when creating an awareness, we need to look at citizens. So in the second part of your answer, can you emphasize on if there's a role as well for patient organizations?
There is a role, a very important role, I think. And if you look at the guidelines developments, but also implementation of care paths, you have to talk with the patient, and the patient should tell us what he think or she is think it's important. It's also about shared decision making. So. That was the answer to the second one. What was the first question? I don't know.
Well, how can we be more successful in delivering the nutritional interventions and achieving the goals? So in the end, we want to reduce the malnutrition. I think that would be the goal, isn't it?
If I may try to approach that, I mean, this is the ultimate question, but at the end of the day, again, I think that we need also, for instance, for a successful program in healthcare, you need resources. So again, if you don't have the recognition and the resources to do it, we are talking about, okay, we have this tool, we have this other tool, there are primary care physicians, there are geriatricians, we have all the educational programs, but we also need the resources to implement them. So again, I don't know, different countries coming from ESPEN, which is international organizations, have very different situations. And we are in a country where I think there are many examples of best practice that can be really useful for other stakeholders in the room. And so this is really important to listen to them. But then again, I think we have to maybe if we have to identify one point is the resources and the awareness in the policymakers, because we have all the, I think, tools, information that we can share. And patient advocacy, again, I think it's a very important, by the way, EPF did endorse the Vienna Declaration on nutritional care. We, of course, were in touch with the central, so I'm happy to say that we are together in that declaration.
You like to respond, Manuel?
Yes, yeah. I want to say something. I think that the main resource is the patients. The patients could be sustainable, the health system in every country, but well used. Use the patient, use the patient correctly. If you educate the patient, and educate is in the consultant, with the doctor, the physician, with the all information clear completely, what I said before. Patient get information and knows what could happen if they do or if they don't do anything. They need to get options to choose. And if the people knows what is the consequences of their action, you are forming, you are educating the patient. This is the first step. This is the first step. If these people is inside of one patient organization, maybe could be environmental contact. Mm-hmm. I don't know how to say. And this is growing up inside. And we could do our job as patients. Education, the physician. We could educate the physician. So we say, oh, no, that's impossible. Yes, we could choose. We could teach you. We could, because no one knows about me more than me. No one. No one. My nephrologist is with me 35 years. My disease is with me 46 years. I know more than nephrologists than me. No one knows than me. So ask me, because I could. If we have this relationship, we could improve engagement, adherence.
And also like personalized nutrition care. Maybe for the last few minutes, are there burning questions in the audience you'd like to address to this panel? Yes, please.
So you know, when in research, when we're writing grants, it's becoming more and more important and necessary and mandatory that we have the approval of a representative of a patient. That we're letters
from the patients.
Exactly, if we're asking the right questions. So how is that in nutrition or more in implementation research? Are, like, for instance, your tool Were there representative of patients that were helping you design the tool, etc.? So I think that's also like something we could take advantage of more. So,
co-design, patient and research.
And I know when there's a lot of research there to develop effective interventions that also are going to be implemented. It's indeed necessary that from the start you involve patients, not only for a letter of support, but really involve them and ask them about what would be necessary, what would you need, how would you do this, and then together and also involve the other stakeholders, of course. So not only everybody who should have a role in the intervention should be engaged from the start. And then you can really develop implementable, whatever, or it is a successful interventions, questionnaires, etc. So I think that would be a start.
Thank you very much, Maria. I think we have to wrap up this session. We started with the question, what are actionable recommendations to improve the continuity of nutritional care in our health systems? We heard a lot of good ideas from this excellent panelist. I would like to thank them very much for their help with this difficult question. What we learned, I think, is that we have to cooperate. We have still a mile to go to have final success. But if we have this kind of meetings, we exchange our ideas from the different perspectives, how we look into this specific matter, then we will succeed finally. And I think it's now time for nutrition for ourselves. So we close this session, we go for the lunch. Thank you very much.
Okay. So I can see that during the last hour or so, everybody got some good nutrition. That's good. And I also like to announce that whatever is left over here today is going to be given to homeless people of this city, so they can have a nice meal. And we're now moving into the afternoon session, obviously. So we have two sessions, and the first one is going to be about good practices, supporting implementation of European policies and guidelines. That's the heading for the first session this afternoon. And one of the projects that have been ongoing is this Europe Beating Cancer Plan, and where we have been also pushing for EU4 nutrition into this as part of that, and it's a successful driver for local implementation. And it's my pleasure to introduce to you Professor Alessandro Laviano. He is, if I have a question about oncology and nutrition, this is the man I ask. I don't think you need any further introduction, so welcome.
Thank you very much. Thank you very much. I need the flicker.
And I will also get the...
Oh, fantastic.
Do you have the pointer?
Thank you for that. Okay, first of all, I would like to thank Joost, Ulle for the invitation. And during the next 15 minutes, I would like to describe what are we thinking we should be done at the European level. Of course, this is my potential conflict of interest. Unmet needs. Let me tell you my view of the last 50, 60 years of oncology management history. So 50, 60 years ago, cancer was becoming a global threat because of pollution, because of cigarette smoking, whatever. So in the end, we had to decide which is the outcome measure we want to address. And we said survival. And these had terrible consequences. I'll tell you why. First of all, are we now very good in reducing mortality in patients with cancer? Yes. These are US data clearly showing that during the last 50 years, there has been a decline of approximately 25 to 30% in the mortality rate, which is a great, great achievement. Although you can see here that for some cancers, there are still a big problem, like pancreatic cancer, esophagus cancer. They were dying in 1971. They die even in 2019. Now, but the major challenge also here is that we have to be honest, at least part of these results is just because we now diagnose cancer at an earlier stage than 50 years ago. But anyway, I think we have to change our way of thinking, and this is what we are trying to convince the people at the EU level, saying maybe survival is not the best outcome measure for patients with cancer. This is a different way of measuring our management of patient cancer, which is called cure fraction. Cure fraction is the proportion of patients with a specific disease who reach the same life expectancy of the general population. Thank you very much. Thank you very much. So you see here, for example, for women and breast cancer, you have more than 50% of people with the cancer who reach the same life expectation of the general population. But look, it takes 10 years to get to this result, which means that cancer is becoming a chronic condition. And if you have a chronic condition, you have to think something different. For example, quality of life. And the consequence of focusing on survival means that we intentionally or unintentionally forgot the patients. Because when you address survival, you address the tumor. You don't address the patient with the tumor. And therefore, you see, for example, this is a consequence of only addressing survival. During the last 10 years, the number of cancer survivors which report functional limitation has more than doubled. So we have more patients who are cured, or at least whose disease is controlled, but they have some functional limitations. So interestingly, we know very well that functional limitations are quite widespread in patients with cancer. These are patients with colorectal cancer. You see very nicely here that there is a reduction in the function of these patients. For patients with lung cancer, is even worse. Interestingly, you see that the sharp decline is during the first year after diagnosis, which suggests, although it is not, of course, an evidence, suggests that during treatment, we are reducing the functional capability of these patients. Now, if you look at the literature, indeed, you will see that the main goal, again, is survival. And interestingly here, these are a number of trials reporting quality of life outcomes. You see that overall survival in 17 studies reporting an improvement in overall survival, 10 actually said there is no difference. For progression-free survival, you see that there are here 27 trials are showing an improvement, but 4 trials actually show that quality of life is worsening rather than improving or stabilizing. Interestingly, if you do look at the literature, you will see that there is this kind of informative censoring. So they're not reporting why they are not actually reporting data on quality of life. So there is really, I would say, a misconception of what would be the real goal of treating patients with cancer. Now, we know for sure that nutrition and nutritional status is a main driver of quality of life. This is recent data showing that sarcopenia is really a main driver of reduction of quality of life or health-related quality of life. More importantly, this is really in patients with cancer. Again, low muscle mass is a predictor, as you can see here, of poor quality of life and, of course, also poor survival. Now, the question is, are we, for decades, we are missing something? Are we focusing too much on the disease and not on the patient with the disease? I just want to remind all of us what William Osler was saying, that the good doctor treats the disease, the great doctor treats the patient with the disease, because in my personal practice, I never met a disease. I always met a patient with a disease. Another major problem is financial toxicity, because if we believe that survival is the ultimate outcome measure, of course we will spend everything for that. And you see here the cost of the immunotherapy is increasing. Usually when you have a drug, after a few years, the cost goes down. Actually, this is not coming, it's increasing. And we have a fantastic talk this morning about the economic impact. This is a nice estimate recently published showing that during the next 30 years, there will be countries which will spend approximately $1 trillion to manage only patients with cancer. If you make a calculation, it means that, for example, in a country like Italy, every year Italians will have to pay 0.8% of the GDP only to manage patients with cancer. So it's really becoming not sustainable anymore, and we want to do something for these patients. Now, another major problem is the treatment-associated toxicity. This is probably you know, I don't have to highlight this, you know very well that if you compare the results of diseases, of treatments in clinical trials and the results in real life, you will see that in real life, many drugs are not as effective as they are in clinical trials. That's why everyone is saying, well, try to use more real data evidence, database. That's why, for example, Nutrition Day is a fantastic opportunity to demonstrate that in real life, nutrition is really a relevant factor. Now, sometimes they don't really look at the complications. For example, this nice paper showing that 20% who report substantial fatigue, they go unrecognized. Almost 50% who report from edema, they are not recognized in clinical trials in the real life. Again, showing that sometimes we are focusing too much on the disease and not on the patients. And paying and treating these toxicity costs a lot. This is an American study, but you see that some treatment are really quite expensive, like, for example, the use of dronabinol to treat anorexia and sometimes weight loss in these patients. Now, another important opportunity is that we are trying to, and really related to financial toxicity, is the fact that, for example, immune therapy, which you already know is the class of drug which has been the highest increase over the last 10 years, is not delivering as it should be. You know that if you have 100 patients receiving immune therapy, less than 50% do benefit. But the national health system pays for 100 patients, not for 50 patients. So interestingly, nutrition can make a direct effect on the clinical efficacy of this trial. This is a very interesting study, clearly showing that if your patient is following a Mediterranean diet, has much more opportunity to receive benefit from the treatment. And this is, again, another study published in Science a couple of years ago, showing that if fibers in the diet can really make a difference in the efficacy of anti-cancer treatment. So you see here that there are good evidence showing that we can not replace chemo, radio, target therapy, and so on, but we can improve the efficacy of this treatment, and more importantly, trying to highlight that the patient-reported outcomes is really what is the main and ultimate goal for these patients. Again, of course, if I have a patient with a stage 1 disease, of course, I would not really consider the issue of quality of life and so on. But if I have a patient with advanced disease, I think that we, as it has been said by Manuel and by other people, we need to ask him, what do you want? You want to live and maybe spend 0.5%, 50% of your extended survival in a bed? Or you want to have a decent life? I think it's a relevant question we have to make. All these information are in the pamphlet you have on your chair, well, you had on your chair, or is under you in this moment. Anyway, so you can find this information here, which were actually also published in a paper which has been presented to the European Commission, because I think that sometimes we have to have this approach from bottom up to down rather than down bottom. So I think it's really important that we brought to the people, to our colleagues, all these information because the evidence really is there. So in conclusion, I think that, well, don't accept the word personalized oncology. It does not exist unless you think that the tumor is a person, is Andrea, is John. It's not personalized. It's precision oncology. Personalized oncology is something that we still have to reach, because when you say personalized oncology, you have to consider the characteristics, the needs, the aspirations, and the goals of the patients. Now, so patient-reported outcome should inform anti-cancer therapies, particularly for those patients with advanced disease, of course. The implementation of nutritional care should address unmet needs and quality of life. Could be financial toxicity, could be increased toxicity of these drugs, or poor response to treatments in real life. So I think that highlighting the unmet needs is key to successful implementation of a better nutritional care for the better care of patients with cancer. And thank you very much for your attention.
Thank you very much,
Thank you.
Alessandro. So are there any questions? No, so everyone's really convinced, I guess.
I guess, hopefully.
Yeah, well, thank you very much again.
Thank you again.
Yeah. So the next speaker, Maarten, where are you? Oh, there. I'm going to introduce is Maarten Soeters, and we know each other very well. Did a lot of research together. He's a direct colleague of mine at the Amsterdam University Medical Center, and he's also member of the Dutch Malnutrition Knowledge Center. And more importantly, he managed to publish a book together with 3 other authors. One is here. Yeah, maybe stand up because it's such a, no, okay. But so they published a book together that can be used. It's basically a book on nutrition that can be used for medical students and dietitians and everyone else who really wants to learn anything about nutrition. So, but today you're going to talk about targeting malnutrition from awareness to control. So Maarten, go ahead.
Thank you, Mireille. Not to forget that you actually contributed with a very nice chapter on total parenteral nutrition. For the ones who don't know me, so I'm an internist, endocrinologist, got kind of lost hooks in the field of nutrition. And I'm going to talk about, let's say, the transition from awareness to control. Actually, I thought this is a very boring and daft title. Who has given this to me? I looked back in my ONCA correspondence email, and it appeared that it was myself actually who proposed this title. So I apologize for you. So we're here in the Zuiderkerk, which means the Church of the South, which also means that there's a Church of the North, of the East, and of the West. So in ancient Amsterdam, let's say the Golden Age, 1600s, these churches were built for Protestant people. And it's interesting to know, actually, that Rembrandt van Rijn, the world-famous painter, buried one of his children here. At that time, obviously, it was quite normal that children deceased quite early after birth. But he also baptized the child, so that was good. And Claude Monet, the other French painter, actually pictured this church quite sometimes. So I'd say this is more or less the health landscape. And obviously, I'd like to make a picture which kind of resemble the Netherlands with a lot of tulips. You can, when you're flying in now, you can actually see them standing adjacent to Schiphol. You see a mill. If you look very closely, you can see 2 bridges, these little bridges over the canals. And you can see in the middle, you can see a cyclist. But if you look very closely, you also see the elephant in the field. And I'd say, is someone who does not see the elephant? No, everyone sees the elephant, don't you? Yeah, okay. And I'd say that's malnutrition. So we kind of have the idea it's there, and well, are we going to do something with this elephant? Because this elephant is actually going to stand on all the nice tulips, so it will kill the field. And I think that's quite a good metaphor of awareness. Are we aware of the elephant? And should we do something about this elephant, the elephant in the room? So I was asked to do this talk from the Dutch Malnutrition Steering Group, also as Mireille just said. And I think it's quite interesting to know, because some of you already mentioned that the nutritional care in Holland is regulated quite well. I think we can be proud, but still it's a fight. We are sponsored, not that much money actually, by the government, and we are sponsored by some companies. But it's really a drag, it's really quite some investment to make this group going on. And we're trying actually to make protocols, guidelines, and we're trying to create a lot of awareness. There's two awareness items I'd like to share with you. On the left side, this is actually how we deal with nutrition in the healthcare system in hospitals. So I'm going to talk mainly about hospitals for the last minutes. So up till last year, we had quality indicators. So actually this meant that as a hospital, you were required to give up numbers, showing how you fed your patients in terms of energy and protein. And actually these kind of data that you should give, at some point they thought, well, let's go to another system and make this system more, let's say, process initiated. So you show us the process, how you deal with a problem like malnutrition, and then that's okay. So that actually means that the hospital itself can be in charge of how to deal with malnourished patients. And you already get the feeling that this is mainly about awareness then, and not that much about control. So we need to see, because this was implemented in November 2022, so we need to see how this will be done. The other thing is the malnutrition awareness weeks that have been going around in all countries virtually, and that's something we did as well. So very much awareness. Mireille already mentioned, we wrote this book, and while doing the launch last week, I thought, is this awareness or is this control? While launching the book, we use a lot of social media content to make people aware. So I think we had about 100,000 people following Amsterdam UMC LinkedIn account, seeing this item. We shared it over 2,000 times. We got lots of comments on LinkedIn. We tried to approach university deans to actually have the book getting into the curricula of the medical students, dietitian students, etc. But still, this is awareness. There's no control. We would love to have control with the book, but we're not getting control. So that's a difficult thing. And then I realized, actually, that in 2019, just prior to Corona, I already did a talk in Cambridge, and I'm sure quite a lot of you were there, also already talking about awareness. So while contemplating on this, I really thought we should go to more control. And actually, previous speakers mentioned the word accountability, which I think is very good. Because if people find themselves accountable for a certain process, whether it's nutrition or something other, you might be more successful. Most of you came by plane, I'd guess. But if you come by car into the Netherlands, these are the speed limits. It's a very simple example of where awareness, driving into the country, oh yeah, so this is the highway, no faster than 130. Whereas the control, these are the speeding tickets or the fines, or if you do 130 in the center of Amsterdam, you kill someone, is prison. So that's very much control. Another metaphor for control and awareness, I'd say, is, for instance, the checklists that have been going around in surgery, that have been going around in nuclear power plants, that have been going around in aviation. So I think we could push a little bit more on the control side. The same is actually being done currently with the European Green Deal, where we try to change legislation in such a way, for instance, if it comes to nutrition, that we do much more sustainable plant-based nutrition. Why not do this in healthcare and actually force people to have better food intake in the case of malnutrition? And I'm going to show you a very vivid example for me, what we see actually every time in the hospital. And that is this one. I'm not sure if someone recognizes the two graphs. Actually, it was in the 19th century, and it was in Vienna. So this is the example of Ignaz Semmelweis, so you know the washing hands, the gynecologist, who saw actually the difference between the red line, which was the ward where all the doctors did the deliveries on babies, and the green line, which was the ward where all the nurses did the deliveries on babies. And the nurses washed their hands, and the doctors did not. So Semmelweis noted this down. He actually became accountable. He took responsibility. And at some point, the washing hands principle got more and more important. I'm just showing you this because if you look in a hospital, we think it's very normal that we have infectious disease prevention, that we have hospital hygiene, that we have antibiotic stewardship. So why don't we have proper, I would not say proper, but why is not dietetic or nutritional care at the same level of the infectious disease prevention and programs? And I think that should actually be the case, whether it's hospital or first line. So I'd say we should become more in control or become more accountability. We can do that actually by addressing these in the items of the care, teaching, and research, which I think is very important. But I really do think that we, even in Holland, where nutritional care is being quite well organized, that we should put the nutritionist or the dietitian in the lead as a professional, not under the doctor, but same level or even higher when it comes to nutrition, and perhaps thinking of making medical subspecialty in terms of nutrition. The last thing I think is very important, that we should involve, if we want to gain control, we should involve more younger people. I see a lot of young people in the audience. I don't see them here. And I think if we make the younger people aware, then at the end they will care and take control when it comes to malnutrition. Thank you.
Great speech, as always. Thank you very much. Do we have any questions from the audience? While you're thinking, there's one thing that I've been finding in working with enhanced recovery programs and changing practice is audit. Because what we're finding is that in many of the basic things that you would think happen every time, they may happen, but not every time. You know, so, and once you start to show people that they're not producing 100% of what they believe they're doing, they usually pull themselves together in hospitals and say, hey, let's get this done. Do you think we could do something similar with nutrition?
I think we should. So this is about this accountability. So sometimes I say, you know, nutrition is something which concerns everyone. Everyone has an opinion, you know, whether it's about disease or whether you want it on your plate that day. But nobody really takes the responsibility in the end. So it's kind of a vague, well, environment where we're in. And I'd like the metaphor with the infectious disease program, where we're very stubborn and rigid if it comes to antibiotics. Why not on scoring people's risk for malnutrition and actually making sure that the amount of protein and energy is going in?
Yeah, yeah. Anybody else? Yes, please.
Thank you very much for your conclusions regarding dietitians. They should really become in the lead, I believe. But I would argue about medical subspecialty. I would rather propose supra-specialty, because subspecialty means you choose one basic specialty and then allow specialization. From our perspective, from the Czech Republic, we have supra-specialty, so it's open to all other basic specialties to take this supra-specialty, and it's creating better environment, I guess. If we have more basic specialties allowing to supra-specialize in clinical nutrition.
I think you make a very valid point. So in the Netherlands, there's different specialties that actually take care of nutrition in the hospital, and these can be gastroenterologists or surgeons. A super-specialism could be a very good way to go, and actually we have some examples of these in the Netherlands, like advanced care medicine, and we could do something like that. Absolutely right, yes.
All right, well, thank you very much. Thank you. The last speaker of this session is Michael Hismeyer. He's a professor of intensive care and critical care from Vienna. He's most famous, though, for having run the Nutrition Day, started it all and been running it now for many, many years. And it's a huge, fantastic project. And now you're going to tell us how we can use this for implementation. What can we do with it?
Thank you very much, Ole, for your kind introduction. Thank you, the ONCA team, for having me here with you. Ole was, I think, in some way at the origin of the Nutrition Day project, because he asked us in a working group, and a few from this group that sat together in Geneva, and he said there was a political declaration, the resolution from the European Council, can we do something about it? And at the beginning of this idea then was, can we do an action to promote it? And what we as a group, and Miguel, I think, is the one that sat in the same room, we said it's maybe not enough to speak about awareness. We should also have data, because it might be that in certain areas of the hospital there may be hotspots. And we already this morning heard when this idea, should we look on the whole population, we heard we may have, I think Rocco mentioned this, we may have to concentrate on some parts that we can select by some procedure that are out at the moment. So this is the kind of origin, and I will speak not about data, but in some way about observation. And how can we utilize this data? I think we can utilize data if we understand them. And this would be the point. These are my disclosures. I have worked in the past with many companies, and some are supporting some analysis, and we are quite happy about this support. What is Nutrition Day for those that are not so much aware of it? It's primarily what we heard just from Ole. It's an audit idea. It's a one-day cross-sectional audit, and it is done in healthcare institutions, in nursing homes, in intensive care units, and now we are approaching primary care so that we are looking further. It's free and very easy because it's essentially formulated in lay language, because there is the patient-centeredness was at the beginning. We thought that the healthcare professionals are very busy and that we should use the patients as source of information. And so I was really happy to hear Manuel this morning about this, put the patient in the center. Of course, the caregiver have to tell us what type of care they are intending. Of course, we ask then the patient what type of care is reaching you, because as I will show you at the end of my talk, some of the care that is intended is not reaching the patient. We have no language barrier because we wanted to include in this type of audit also patients that do not speak the main language of a country. So the beginning was we need all European languages, and now we are working in 35 languages. So we saw Seoul from Alessandro just before, so it's in Korean, in Chinese, in Hebrew, Russian, whatever you want. So, and at the end, how can we work if we are not giving something back to the healthcare institution that is participating? There is a unit report that provides the audit mechanism. It compares with the same specialty. But of course, doing a cross-sectional data collection was in some way, as you see, we have only one day where we collect the information, and then a key issue, we look after 30 days in hospitals about outcome. So this was one of the first time that collecting risk factors that are brought by the patient into the stay. There are some risk factors potentially or beneficial factors like intensive care stays before the observation day. And then it's very important whether there is an association with outcome. And I will share with you some of this data. And you see that from the beginning we saw a kind of continuum from outside the hospital, then you go in, you are in the hospital, and then you go back into the community. And I think this is today's topic of this meeting. Obviously, this cartoon comes from an architect, and she is an architect of healthcare. And I have borrowed this from Magdalena Meyerhofer. So, and what are the mechanisms? You can fit in screening by asking the risk factors. Then you act. We have a little bit the weak point, as I will show on the monitoring, I think. This is not as much formalized as the screening has been. Okay? Since the beginning in 2006, we have 300,000 patients that have been included in the different areas of the project. And for this time, I specifically looked at European data because it's a European initiative. And out of the 200,000 patients from the hospitalized, there are 125,000 that are from Europe, and I will focus on the right-hand side. You see the most recent cohort that is here, the 22,000 that are from Europe since the year 2016. You see that these patients are about 70-year-old. They are becoming slightly older in the newer cohort, that about in the hospital 50% are women, a little bit increasing the proportion of women, maybe, but it's very slight. It's very different from intensive care, where we have 2/3 of men in the ICU. It's very strange that there are this difference, or 60% typically. The length of stay, as it is a cross-sectional trial, is 6 to 7 days. When you look at all patients that are now in a hospital, the median is 6 to 7 days. That means that half of the patients that are in a hospital are already longer in this hospital than 6 or 7 days. And when we heard this morning that 3.2 days is the length of stay in the Netherlands, this is a mean, but this is not the burden of work of the healthcare workers in the hospital, because they see the patients that are present and not the running through patients. So this is an important, and you see that our model for mortality, that is the Pandora score, quite well fits to the about 3.8 to 3.1 mortality of actual patients staying. I would like to share with you, this is now the profile. If you look at how many days have patients already been in hospital when you collect data on nutrition day. And what you see here, 40% have, and you look back in time from day one, so that if it's on a Thursday, that would be admission on Wednesday, then it goes back until 1 month. 40% of the patients have been admitted between Sunday and Wednesday. Then you see the first hole here, you see a second here, a third here, and you see the fourth hole. This is the weekend admissions. Even 4 weeks later, you still see that there are fewer patients that are admitted on weekends. I can tell you from the point of outcome that patients that are admitted in the holes of the profile have a 50% higher mortality compared to those that are before and afterwards. And of note, 10% of the patients that are actually in Europe staying in hospitals are already there for a month or longer. And that makes a lot of treatment days, of course. And this factor of time is very important, as I show you here on the example of low body mass index, just one observation. And when we look back in time again, we see that in each time slice, the proportion of those with low BMI increases. Those that are here already 1 month have 15% with a very low BMI, and those that have been admitted yesterday, they have only 5% low BMI. What does it mean? It means this is now the other side of the coin. How long will they stay in the future? That first, they are more discharged with a higher BMI because you have a lower proportion, and then with a longer stay, then those with the low BMI are discharged. The blue line identifies the mean of the total population. And that means that when you look at the population, you have also to look what are there in their time course, their life course in hospital. It's very different when you look at the profile of risk factors. And let me look at one risk factor, and now I do not look in isolation at nutrition, I take usual mobility. Because when Manuel said, am I interested in the 6-minute walking test? No, I'm interested how I'm performing. And this is now, I'm mobile with help in orange, I'm mobile with a cane in green, I'm mobile with a wheelchair in blue, and I'm bedridden in red. And you see about 40% of the patients have some limitations that are actually in hospital, had before already some mobility limitations. And these mobility limitations are associated with a large increase in mortality from 1.5% for the white ones to 5%, for example, for the blue ones that are in a wheelchair, and to nearly 14% for this 5% of those that were bedridden already before. You may say this is just because of age. If you look at the profile adjusted for age, you find exactly the same profile, and the odds ratio for death is, for the blue ones, is about 3. Yeah, so within the next 30 days. So that's quite an impressive difference for me. This is then, now let's look, beside this patient-oriented factor, let's look how they were eating before admission. And you see that roughly 38%, this is the blue ones at the bottom, have eaten 3/4, half, or dark blue, a quarter or less. The orange ones tell us, I do not know how much I have eaten, and the gray ones are the missings. And again, you see here that the odds ratio goes stepwise up already if you eat half, a quarter, and those who say I don't know are at the highest risk. And the missings are also high. What this tells you, in research of this kind, do not disregard the missings, because the missings are informative in this case. The missing tells the situation is not clear for me. And the I don't know, this is actively telling I don't know, means also there is some background. And you see that it is adjusted for sex. So male have a nearly 1.6 odds ratio, and this is an age adjustment. So it's not the factor of age that determines this eating association. When we now move from eating before being admission, and you see how many more the gray ones, we are now at 58% do not eat their full meal. So only 42% eat their full meal. It's nearly increased by 50%, the non-eaters. And again, you see here this profile of increased risk. And of note, there are orange and red ones. The orange ones, they do not eat, despite the fact that they are allowed to eat. And the red ones, they do not eat because some in the doctor team or in the nursing team said, you should not eat. Both are with increased risk, but they have a big difference. So eating nothing needs to be in some way differentiated. And you see, again, the adjustment that works for age and sex. We have developed a scoring system to predict mortality. The Pandora score, just one example. I stay in bed, 11 points. 11 points is being 70 to 80 years old compared to below 40, or it is equivalent to eat nothing despite being allowed. So you could say, if I stay in bed, it's equivalent to be 40 years older or to eat nothing. You can in some way balance the risk factors in their weight for outcome. Now, why are people not eating? And this is some research from my co-developer, Karin Schindler, from the project, I must say. And we looked at who does not eat all. Who are these 58% that are not eating? And what you see here, when you are going, the odds ratio goes down, means less eating, and above it means more eating. There are some organ function, but look here, this is the age profile. The old eat less and the young eat less. And we were very surprised. But it means it's uncommon, probably, to be young and being in a hospital. And you may be with a severe disease. You will be very surprised when you look at this. This is in different world regions, and you see this blue profile is everywhere in the world. You find this same U-shaped association between eating less and age. But let's look at this factor, eating less last week. The blue ones, of course, play a role. But why did I show mobility? Because reduced mobility is also associated with eating less. So I think there is a link between the functional activity that is possible and what you are eating. And this is a recent research done again by a healthcare architect. It's Maya Kefzia, and what we analyzed together is the data about food intake change. This is now in the new cohort. We are asking about, did your food intake increase? Is it unchanged, or did it decrease during your hospital stay? So this is now these 7 days that the patient have as a median been here. And how did your strength change? You became stronger in green, you are the same in gray, or you are weaker. And I would like to focus your attention that about 1/3 of those that said we had decreased food intake contribute to over 50% to those that also are weaker and feel weaker during their hospital stay. So in a hospital, patients develop in two directions. Some improve and some get weaker. And we should address these populations maybe separately because they are different targets. No. And now I'm approaching the end, I must say. This is now about, I think we have found this prevalence of risk factors is universal. But so is it bad to have patients with risk factors in hospital? No. It's the place where patients with risk factors should be. But we should do something about it. And this is now which nutrition care is provided to patients that indicate themselves, the patients, I eat half or a quarter, the blue, or red on the right-hand side, I eat nothing. Let's start with the blue ones, so the less eaters. Remember, the less eaters have approximately a 3 to 4 times higher mortality within the next 30 days. So it's an increased risk group. And look at enteral and parenteral nutrition. Overall, it is below 10% in surgical patients, and it's below 5% in medical patients that get any, let's say, clinical nutrition to accompany or to support this condition. It's slightly higher, the support that is given. The orange ones are preoperative, the red ones are postoperative, and the blue ones, I forgot to mention, are medical patients. You see, the profiles are rather similar, yeah, with small differences, of course. But below 20% of preoperative patients that are not allowed to eat receive any clinical nutrition. Below 33% of postoperative receive clinical nutrition, and below 22% of medical patients. So there is quite some room for improvement. I do not know whether it should be 100%. There may be some that are not benefiting, where it is terminal care. There is something open, and now, why are we here? Are you here? Because countries are different. This is from Noemi Kiss, an analysis where we looked at what outcomes do we have to consider. And there is the violet outcome is discharged home. The lowest proportion is here in Czech Republic with 54%, and the highest was in Turkey with 83%. And then green means transferred, and blue are still in hospital. Between 5 and 25% after 30 days are still in hospital. So these are long stayers. But the green ones, some 2 to 25% are transferred to other healthcare institutions. Usually we don't see the outcome of these people. This may be a chronic disease, may be referred, we do not know. These are those, and in the United States, these are early transfers into this region, and that's why the outcome is so good in the US, because if all the poor patients are sent to other institutions, then of course you don't observe what's going wrong. We are now in a new project that we have done the pilot this year, addressing primary care nutrition, and you will see some results. I would like to congratulate the groups that have done the pilot with now more than 3,000 patients that have come in. You see examples here of the reports that are going back to the unit that support benchmarking. This is just an example. How are you weighing your patients at admission? In one unit, 83%, in another unit, 12%. And you can compare to the country, the region, nutrition day, or the top units. And you see there are differences. And then you can decide in your unit what to do about it. Country reports have been published in Clinical Nutrition Aspen. There is an annual report intended now, and so I come to the conclusion. I think I try to show to you that patients bring into the hospital, so it's a kind of life course issue, characteristic and risk factors that are associated with several outcomes, staying longer or shorter in hospital, but also dying or not dying within the hospital stay. The risk factors change over time. It means that there is a selection process. And what you observe on day 20 of stay is the leftover of between those that are discharged and those that are admitted. That's so simple. I wanted to show you that mobility and eating are related, and that we might look a little bit at these things in some way together, because they are influencing each other. We have created the idea of a walking hospital that I can share with you another time. Not eating is not always recognized. It's not monitored appropriately, and the care is not appropriate, I would say. And I think nutrition, what does it contribute for advocacy? It contributes on the one side with knowledge, on the other side with awareness of those that participate. It allows up-to-date data to be shared. It allows objective benchmarking and not impressions. And it is actually, I think, the largest worldwide reference database for this kind of risk factors and care. Thank you very much for your kind attention.
Fantastic. Always good, always good. Isn't this a fantastic project? I think it's absolutely amazing what has been achieved. Any questions? I have one for you. Now, you show us data from the different countries. Is there any way of getting some sort of validation of, for instance, the length of stay that you're looking at by looking at national data from somewhere else?
In this paper, length of stay with the data that are available at admission has been analyzed. Mm-hmm. She's doing a second paper, what is the length of stay after nutrition day? So this is done by country, and the risk factors have been identified. It's very classical, I must say. And there are significant country differences. I did not point to those countries who have systematically long stays, like Japan, for example. It's typical that when you have 6 days in Europe, it's 14 days in Japan. That's how the healthcare system is organized. We do not blame. Nutrition does not say what is good and bad. It's how the data are, and you have to decide what is good or what do you wish to change from that. And the observation is that the risk factors are universal, I must say.
Perfect, thank you. I encourage everyone to, oh, there's a question in the back. Yes.
Can we have the microphone?
We need from the microphone in the back, see? Yeah, there you are.
No,
A good presentation. In your presentation, you told about low BMI, and I saw that the patients were over 60 years. So did you correct the age, the BMI? Because we know, everybody knows that the BMI of 22 is lower than BMI of 22 is when people are aging. For us, below 65, it's 20, but if you are aging, it's 22.
Yeah, but I would in some way challenge you, because this is the current way of thinking. But if you observe large populations, the BMI of older age is going slightly down. And we have analyzed the different cutoffs for poor outcome that is also written in the guideline, and apparently even in Asia, it begins the poor outcome adjusted for age, etc., between 20 and 22. It goes up in old world region. I think there is apparently some kind of magic limit somewhere around 20 to 22. It's just a group, it's just an example. You know, I could have shown the obese one where it is reversed. It's just an example that the length of stay is a kind of selection factor in hospital. It's not saying that this is the appropriate cutoff for all the same. I think the picture would look the same if I would, let's say, low BMI and differentiate it by age. We would not be much different.
Thank you.
Okay, well, we thank Michael. Big applause.
Thank you.
And I'd also like to thank the audience that has been with us online. The broadcasting will end now, so thank you for being with us.